So just a little bit of background about why I'm the person talking about this. I'm a GP and ex-hospice doctor, but I'm trained in psychosexual therapy and I'm also trained in sexual medicine. So tend to have that sort of view of what's going on in somebody's mind as well as what might be going on in their relationship, but mapping that to some of the physical changes that women experience as they go through menopause and how all of that can kind of contribute to a change in how we experience our sex lives. Next slide, please. So testosterone is something that I'm going to cover. From Shashi, I've just picked up that she's talked a little bit about how it changes really over the menopause transition. I'm going to be looking at how we prescribe it, but also how it fits in the wider picture of what we should be doing around supporting women with their sexuality. And generally, I go at this from the opposite direction, which is a mindset that although testosterone and hormones are often a really important sort of ground level bit of work that we need to do to help women to be able to have the best chance of enjoying sex at this stage, they're often not enough to resolve all of the issues that are going on. And we've got to be careful not to ignore some of the bigger mind-based or world and relationship-based impacts that are often much more the reason behind why something is altering for a woman that we're seeing rather than just what's happening with testosterone levels. I'm going to explain what a biopsychosocial lens is because this now comes up in some of the guidelines around what we should do with prescribing testosterone, but we don't always explain quite what it is. And I hopefully will have some time to bust some of the kind of common myths that I hear being discussed around sexuality at this stage. I'll probably end up using the word woman quite frequently, but the information that I'm giving is applicable to anybody assigned female at birth. Next slide, please. So as we've already talked about this morning, and I think we all know these days that testosterone is an important female hormone, and it certainly does decline from our younger years and reaches its sort of zenith in our 50s and starts to rise again afterwards, as Shashi mentioned. We know that we can use testosterone in license when we're prescribing it for women with hypoactive sexual desire disorder who are postmenopausal, but we're also increasingly using it for women at other stages in menopause transition. And we don't tend to understand fully, I think, how it fits in with other approaches that we can use as well that can maximize sexual sensation, arousal, and enjoyment. At the moment, the science basis only supports its use for sexual dysfunction, specifically for raising sexual interest, so raising libido, and also improving sexual satisfaction. So it has an impact on arousal and our ability to climax. We hear a lot about testosterone being used for things like brain fog and to improve lean muscle mass and to improve energy. And although I think any of us working in this field, we're used to hearing women say that they've seen impacts in that area. As it stands at the moment, the evidence base is not great to support that we can advise women that we can expect this to happen for them when we prescribe testosterone for them. So I think it's important to discuss that in clinic when you're thinking about initiating a prescription and explain what is reasonable to expect and then perhaps what women can look out for, but not necessarily know will happen as a result of prescribing. There's no evidence that tells us about the safety of compounded products. So we're talking about using specific testosterone that's in the BMS. So usually in the UK, the NHS available testosterone is licensed for use in the male body, but we follow guidelines to use it in female bodies. Next slide, please. So the products that we have access to, that generally what we're trying to do is to use the boys' products to give women 5 milligrams a day. And we have access, when we don't have problems with supply, we have access to all of the following formats. So we can use Testogel. It needs to be the sachets of Testogel, not the pump of Testogel, which is a higher concentration. These recently changed from 50 milligram in 5 mils to 40.5 milligrams in 2.5 mil sachets. And we need to use this over 8 days. Testim is 50 milligrams in 5 mils and is used over 10 days. Tosteran is incorrectly written on here. Actually, Tosteran pump is only to be used 1 pump 3 times weekly rather than 1 pump daily. I'd adjusted the copy of the slides that I had. And privately, we can access Androfem, which is an Australian product that's been licensed and marketed for the female market. It's not available on the NHS. And again, the applicator, it's a little bit easier to use Androfem because it helps you to get the dose out in a more usable quantity. And we apply 5 milligrams again per day. We need to check through women's medical histories when we're starting them on testosterone, but I think it's important to remember that all we're aiming to do here is to replace levels to the normal level that we would expect to see in younger women, rather than going to a super physiological level. And my general guidance for people who are using testosterone to help with sex is to start with estrogen, get that bit right first, and then if there are still issues, then offer testosterone. Next slide, please. So it's not something that I think needs to be used across the board. I probably prescribe more testosterone than the average menopause doctor, because I work a lot in sexology and with women with low libido. And I find that probably about half of my patients will give up using testosterone after 3 to 6 months because it's not had the impact that they wanted it to have, or that they've experienced some negative side effects with it. The way that we look at blood levels at the female range, the assays in the labs are not particularly accurate at that level. So it's really important to be guided in the main by the symptoms that somebody's experiencing, and to talk to the woman about how she's feeling on testosterone and how she's feeling when we're considering prescribing testosterone. And we're really using the blood simply to tell us that we're not either starting with somebody who's above the normal levels, or when we're prescribing that we haven't gone much higher than the levels that we know are normal for women in their fertile years. There's been a change in how we should be looking at the blood monitoring. We used to talk about using free androgen index, but we now look at total testosterone in the main. SHBG is sometimes useful when it's very high or very low. So if you've got somebody whose clinical picture doesn't quite match the dosing that they're getting, and you're not quite sure what's going on, it's occasionally useful to ask for an SHBG and to use that to help in your interpretation if it's at either end of the scale. Guidelines say that we should monitor levels after 8 weeks approximately of use, and then 6 monthly or annually thereafter. Next slide, please. So moving on really to the wider picture around sexuality, and there's a lot of myths that are there, I think, that we have to sort of bust really. And one of them is that most of your sexual function and how it works is to do with how your body is, rather than anything else that's going on for you. Next slide, please. So I was trained in a biomedical model when I was at med school, which was very much looking at, physical-based definitions of illness and disease. And when we had treatments, focusing those on physical-based problems. But when we're looking at sexuality, we have to understand that it sits in a wider context, and a large proportion of how we feel about sex and our interest in sex is mediated by what's happening in our brains, our sexual identity, the history that we bring, our experiences, good and bad, and also what's happening in our wider worlds. And as Shashi just said in the questions, menopause is a very stressful time. It's psychologically a very challenging time for many people, whether that's at midlife or early. And that has absolutely got relevance when it comes to the interest and the energy we have for sex and where our brains are during that process. We also have to recognize that we don't all get the same information about sex as we grow up, or the same experiences of it. And the sociocultural impacts, the education you had, the access you might have to sexual health care, the kind of messages that you may have received growing up about what's normal and abnormal, desirable, not desirable in terms of sexuality, all of this stuff really forms the lens from which you look at your own experience of sexuality, and crucially whether or not you feel that you're, in inverted commas, normal, and your sense of shame or pride around your sexual experiences and sexual self. And all of this stuff is incredibly relevant when we're talking to women about what's happening in sex at midlife. Next slide, please. So the biopsychosocial model attempts to integrate everything that's happening in all of these areas. I tend to visualize it like a Venn diagram. I normally start my approach with the physical, so making sure that I'm addressing hormone changes and optimizing the state of the body for good sexual function. But I also ask a lot of questions about the kind of messages that somebody may have received growing up, the kind of experiences they've had in their sexuality, because we know that the literature tells us that if sex is going well before menopause, it's more likely to continue to go well after menopause. But actually, most of the women that I see who are experiencing problems have also had lots of other issues earlier in their lives as well, which perhaps haven't been resolved or addressed. And we also need to understand about the partner health, the dynamic, the power dynamic in that relationship, to get some sense of what's going on. Next slide, please. There's also this idea that we all agree on what normal looks like, and that's probably something to bust early on, really. So next slide, please. Sexual scripts is a phrase that I'd never heard until I trained in sexology. Scripts for psychologists are this idea that we absorb lots of information quite unconsciously as we grow up that tells us about something. And when it comes to sex, most of us learn about sex through what we've seen on, in media, in books, what we've been taught when we were at school, the messages that come over, in churches and religious texts, what our parents and friends have told us. And I don't think any of us really consider that our own experience may differ significantly from somebody else's. And it can be quite helpful to think about, how you learned and reflect on that yourself. And it'll give you a greater awareness when you're talking to a patient about some of the issues that might be live or relevant for them. It's also quite important in terms of the doctor-patient relationship because we carry our own scripts into the room, and that can sometimes guide what we believe is reasonable for a patient to expect around their own sexuality, or whether what they're talking to us about is something that we think is normal, or whether we have a tendency to perhaps pathologize that. So it's quite important to bring this unconscious stuff into our own awareness, but also when we're talking to a patient to help them to reflect on what they may have learned and how that may be impacting now. Next slide, please. The sexual scripts that we have around heterosexual sex have significant impact on women's sexual experiences. So the one area that I usually use to illustrate this is talking about the orgasm gap that exists in sex between male-bodied individuals and female-bodied individuals. Now, we know that if any of us are able to self-stimulate, then we normally can achieve orgasm within about sort of 5 or 10 minutes. And about 95% of individuals are able to bring themselves to orgasm in that time frame. But if we put men and women into partnered sex following the sort of typical sexual patterns that we have within heterosexual relationships, that orgasm rate stays high at 95% in male-bodied individuals. But when it comes to women, their orgasm rate has fallen to the mid-60s. When we look at women who have sex with other women, then the orgasm rate stays very high, something like 85%. But when we look at hookup sex, so individuals who are dating in heterosexual relationships, again, the male orgasm rate stays at 95%, but the female orgasm rate has dropped to about 18%. Now, this is not because women's bodies are working differently depending on which partner they're with. It's to do with these scripts, the ideas of what sex looks like and what we actually do when we're with a partner. And a large amount of the scripts around heterosexuality focus on penetration as the main event in sex. But actually, when it comes to how women's bodies are, work at their best for arousal and climax, the stats tell us that women on their own tend to use clitoral stimulation to orgasm rather than any penetration with toys or with fingers. So what people are doing in their bedrooms is directly influenced by what we think we should be doing, and that has a really big impact on how much satisfaction and enjoyment we can have from sex. And that's why it's important to become aware of this issue and perhaps to challenge some of it. Next slide, please. So next myth is that women require testosterone when they have loss of libido. Next slide, please. So I often start by explaining how we're adapted for sex in our fertile years, because I think it's easier to illustrate what changes as you go through menopause and why it might be an impact or be impactful. So during our fertile years, we are really well adapted for sexual pleasure and for sexual enjoyment. So when we're aroused, we experience blood flow into the breasts and the pelvis, which gives us that feeling of arousal and heightens the sensitivity of those tissues to sexual touch. We find that our interest in sex, although it may be present all the way through the month, it's heightened around ovulation, and we tend to be more responsive and have more spontaneous desire around that part of the cycle, which maps to when the hormones are at their highest. The vaginal mucosa is designed so that the higher blood flow that goes in when we're aroused allows liquid to leak through, which gives us that wetness and lubrication that enhances sexual sensation and makes penetration pleasurable. The lining on the inside of the vagina sloughs off on a regular basis. Those dead cells are used to feed lactobacilli, which helps to keep the pH of the vagina low, so it fights infection and supports vaginal health. And it means that we repair quickly from sexual contact as well. So any micro traumas or damage to the lining quickly gets repaired. At night time and in the mornings, we experience reflex erections of the clitoris, just like male bodies get with penile tissue. And this means that the tissues that are kept pretty squeezed out get a flush through of oxygen, and that keeps them healthy and it allows them to keep responding to arousal or sexual thoughts. And we have dense sensory nerves that again give us sexual pleasure. The clitoris's only function is to give us pleasure. Next slide, please. When we go through menopause, there are really fundamental and significant changes in this process. So as Shashi's just explained, we have fluctuations in levels of estrogen, progesterone, and in androgens over time. And this impacts not just the peripheral bodies, so the blood supply, the nerve function, to the parts of our bodies that we tend to involve in sex, but also to the way that our brains think about sex as well. So testosterone is quite important for sexual thoughts, dreams, fantasies, for example. We get less blood supply into the pelvis postmenopausally in women who don't have HRT, and the vulval and vaginal cell turnover falls, with the tissues thinning up to 2/3, becoming less stretchy, so less able to accommodate penetration, and vaginal dryness becomes more problematic. We also see changes in the bladder and in the bladder sphincter, which means that urinary problems and leaks can become more of an issue. And as we lose the glycogen storage in the vaginal cells, which is supported by the presence of estrogen, we are less able to support a healthy colony of lactobacilli. So the pH of the vagina rises. And we also see that the clitoral tissue will shrink over time and become less sensitive. And women will talk to you about this. If you ask them, they'll tell you that they've lost that sort of structure and architecture in the clitoral tissue. Next slide, please. So the consequences of this for sex are really quite impressive. And I think what I find most when I see people in the patient is that they haven't been told to raise these issues with their caregiver, and it means that they've allowed things to become quite progressive by the time that we see them. So raising awareness is really key, because once somebody's developed a problem, can you go back on the slides, Fiona? It just popped forwards. So sorry, thank you. When someone's developed a problem, they then start to develop thoughts and meaning and behaviours around that problem too, so that the issue sort of spirals from there. So women are more likely to experience pain with sex. This can then lead to the development of vaginismus, which means that penetration feels difficult or even impossible. We see more prevalence of things like itch, dryness, tears and fissures. There are more bladder problems. The pelvic floor muscles become weaker, which leads to urine leak and prolapse, but also impacts the quality of orgasm. And we often see negative sexual consequences, such as increase in urinary tract infections or irritation after penetrative sex. Next slide, please. So what do we need to do about this? Well, as I said, a baseline from my perspective is to talk to the lady about HRT and whether that fits in her frame of what she would like to do, but also look down the list of other medications. There are some really common culprits like antidepressants, antihypertensives, including beta blockers and antihistamines, that can also be increasing dryness and making climax and sexual interest much more difficult. We need to work with somebody's wider health to make sure that the blood supply and nerves are working as well as possible, and to adequately treat pain, because your body as a tool for sex can be really impacted if you have reduced mobility and pain. And we also need to think about what's happening in the partner. It's important to look after the vulval tissues and the vaginal tissues. So absolutely thinking about vaginal estrogens internally and externally, but also there's a role for moisturizing, using massage, which improves blood supply and supplety of tissues, and ensuring that we're using things like emollients to wash, so we're supporting health in these tissues. Giving some advice about pelvic floor muscles, not just strengthening them, but also how to relax them when you want to treat things like vaginismus that's occurred in response to pain, and checking that women have good bladder function. They won't tell us about this. They might be leaking during sex or leaking during orgasm. We have to actively ask, because women won't raise this in the clinic with us. Next slide, please. So I've talked briefly about testosterone at the start of what I'm talking about today. I mean, I think the overall message from me is it's valid to try in anyone who wants to try it. It's particularly important to offer and think about in women who have had their ovaries removed, or those who have had significant damage to the ovaries. So women who've been through cancer, for example, or had chemotherapy or radiotherapy may fall in that camp. But I would always encourage you to make sure that the woman's got adequate HRT estrogen in the first instance, and also crucially that she's applying estrogen to the vagina and the vulva, because we don't do things we don't enjoy. And when we have reduced arousal, or we start to experience pain and discomfort or negative consequences from sex due to local estrogen loss, that has a massive impact on interest and libido, and women will often avoid intimacy for that reason. Next slide, please. So I always say ask questions. When most of my referrals to clinic come in under the banner of loss of libido, but when I talk to somebody about what's going on, it's really evident that loss of libido is the final common place we get to when we have problems with sex. So be curious, find out what came first. Next slide, please. This is a deliberately messy slide, and it's to illustrate how messy the issue is for most of the women that we see. So my point is that almost anything that can happen as a result of the physical changes of menopause, which are all illustrated in the blue boxes, can very quickly lead on to other associated problems. And ultimately, when sex becomes problematic, makes us feel bad, we don't want to do it. So loss of libido is kind of an umbrella term, and we need to ask questions. Around the periphery of this slide, I've put in some of the wider issues that also might be impacting, such as low self-esteem, anxiety, what's happening with a partner. And if we don't ask women about all of these things and draw their attention to what's happening in their lives and relationships and how that's impacting, we'll often find that testosterone does very little on its own to resolve things. Next slide, please. So the other myth is about monogamy. So this is a real sort of sexual script that we have, that if you've got the right partner and you're in a good relationship, that sex will continue to be something that you want all the way through your life. And that's definitely not something that is always true for everybody. Next slide, please. So again, there's not time to go into it in detail, but I just want to normalize the fact that desire in long-term relationships is something which is often problematic. The closer we get psychologically to our partners, the more we attach to them, the more we are intimate with them, and we show them parts of ourselves, as in terms of we share information about ourselves and we're accepted by them. That closeness that happens from an attachment perspective can often mean that sexual arousal and sexual interest diminishes. We often need to have some level of distance or something that's unknown about a partner to be able to really see them as sexy or to eroticize them. And we know that these things are almost a paradox, that the more we become close and attached to a partner, the more difficult it can be to access that spontaneous desire at times. The theory behind some of this is that our wiring for sexual interest is based on novelty, and the kind of genetic basis for that would be that it allows us to share our DNA more widely, and it optimizes our chances of having, successful offspring. But it's not very helpful with the culture and the kind of frameworks that we live in our society. It's known as the Coolidge effect. The body will produce a larger physiological response to the possibility of sex with a new sexual partner, even when we have access to an existing sexual partner. So in studies, we know that men produce more ejaculate, they have more motile sperm, there's more blood flow into the penis with a new partner. This is not helpful at all for us in long-term relationships, but it often accounts for much more of what's going on in terms of desire than hormones alone will actually help with. So often I destigmatize this with patients, talk about it, and share resources to help them to understand what we can do in long-term relationships to improve this. And Esther Perel has written a couple of really good books which are worth sharing with your patients on this subject. Next slide, please. This is the erotic equation. This is the idea of what I've just said, really, that if we're attracted to something and we can't have immediate access to it, it massively increases our desire for it. So this is what we need to fire up our desire. Next slide, please. So in long-term relationships, when sex with a partner is often freely available, we have to do things that help us to access some novelty and to rekindle that interest with an existing partner. And it means that going to psychosexual therapy can often be something that's much more impactful than just giving HRT alone. Most of the themes are around allowing individual space and individuality within a relationship and allowing for mutual growth. So there's a tendency sometimes to merge into one identity in a couple, but actually it's much more helpful for sexual interest often to nurture some space, some time away, and to be able to come back to that partner and share new things about each other, which allows us to eroticize the other. So we can nurture time as individuals, and we can also use forms of sensate focus, which is a psychosexual therapy skill, which is effectively graded touch. We take penetrative sex off the agenda and get couples to focus on touch and pleasure. And this allows them to release hormones such as oxytocin and dopamine and vasopressin, which allow bonding and connection to a partner. And this fosters desire and intimacy. So there are techniques that we can use to do this. Next slide, please. It's also really useful when we're talking about sex to ask a patient what's happening on their own, because that'll often give us clues as to what the cause of loss of libido or an arousal problem actually is. Partnered sex is difficult. We have to manage the partner's expectations. There's often a pressure on us to climax. About 60 to 80% of women will fake climax because it's something that helps the ego of the partner, so that there can be that sort of pressure. We have to deal with partner issues such as performance anxiety, ED, and heterosexual relationships. Often, if it's women having sex with women, we've got two women going through the same issues, usually at menopause as well, which can complicate things. And the communication around sexuality is often really poor because we can hold shame about these things. So most of the couples I speak to aren't talking about this. They're tiptoeing around the issue, going to bed at different times. Often other parts of the relationship are working really well, but there's no intimacy, even hugging or date nights, going to bed at the same time. All of that is avoided in case it's taken as a green light for sex. So in order to start to improve things, we have to support communication around this issue, and help people to talk about what's going on for them. Next slide, please. Okay. And one of the other myths around libido is that it's like hunger. It's something that's spontaneous and kind of is there as as an appetite within us. And that's certainly not always the case for most of our patients. Next slide, please. So there's lots of detail on here that we don't need, but I just want to illustrate that sex has science to it, and sexologists have been trying to work out what happens with our sexual interest and response from about the 1950s. And the models that traditionally were talked about had everything in a nice smooth order so that we, felt excitement, we'd get an increasing level of arousal, hit orgasm, and then go back down to baseline. And as the sort of science of this developed, we started talking about the role of desire in this process. And it was always assumed that this was a spontaneous thing, a bit like hunger or thirst. Next slide, please. And there was a doctor called Rosemary Besson, who developed a different model of how desire works by studying women in long-term relationships. And she realized that actually desire is not always something that's there spontaneously. It's high early in a relationship for the first 12 to 18 months. But after that point, spontaneous desire tends to fall a little bit. And women in particular will experience more of their interest in sex as a responsive thing. So I always use the analogy that, hunger might be spontaneous desire, but walking past a bakery and smelling the bread baking is more akin to responsive desire. We have a little bit of arousal from something, and then we remember it gives us pleasure, and then we want to do that activity. And that's often the route back into desire for women in long-term relationships. It's about slowing things down, looking at what might be getting in the way of putting ourselves in the context where we may feel a spark of arousal or interest, and looking at what might be impacting our willingness to continue down that path into intimacy. And the things that often block that for women at menopause are issues around self-esteem, concern about how their body may work, concern about some kind of negative consequence of going on to have sex, like pain or dryness or a UTI. And when you sit with a patient and you break this down with them, it makes a lot of sense to them. And it really helps to support people getting back to better intimacy over time. Next slide, please. Okay, this is just another area around hormone loss being the main influence on libido. So if we can push through to the next slide, please, Fiona. So most of the models we have around how arousal works in the body are focused on the idea of it being a dual control model, like there's brakes and accelerators, or some kind of a seesaw that happens in our bodies that balances all of the things that might increase our turn on with all of the things that might put the brakes on that. And again, it's another model that's really helpful to talk to patients about, because then you can explain to them that there are some things we can do that help us to step on the accelerators, and hormones and testosterone sit on that side, but it's not all that's over there. And there are also things we can do to take off some of the brakes and improve our interest in sex and our arousal. Next slide, please. So some of the sort of, these are labeled incorrectly. I changed these on my set of slides. So can you go to the next one, Fiona, first, and then I'll come back to this one. So this is looking at the physical factors, just to give you an overview. Some of the brakes that we have are anything that's impacting the menopausal hormone changes. So all of those tissue changes that I've talked about in the vagina, the vulva, and the things that are impacting the brain and the wiring. So considering and using HRT can be incredibly useful, but also all of the other factors that are changing how our bodies may work at menopause, whether that's diabetes, high blood pressure, medications for antidepressants, and so on. Looking through all of those things helps us to address some of the breaks that may be there. And if you can go backwards, I'll go on to the social factors. Thank you. These are the social factors that may also be putting the brakes on. So again, as I've explained around novelty, in long-term relationships, sometimes the break is there through boredom. It's a sense of obligation to a partner rather than real desire to have sex. Sometimes the sex is not very good. You've got an unskilled partner, or you've been typecast. Everyone's going from A to B to C without really changing what they're doing. Or we might be holding resentment from other areas in the relationship. If your emotional needs aren't being met during the day, you're much less likely to have that openness and willingness to meet other needs later on. So we have to think about that, and also the fact that sometimes we're not actually expressing our true sexual preferences and interests within a relationship as well. And many people carry shame. So shame is not guilt. It's not having done something wrong. It's a sense of being somehow wrong. And this can all stem back from early social, cultural, or religious scripts or previous trauma. What helps with all of this is understanding your own needs first and foremost. And in therapy with patients, I start there on what they find pleasurable, what they find interesting, and then we broaden that out into the relationship. So if you can skip through 2 slides for me. Thank you. Almost done. Myth 7 is just looking at performance anxiety, because I think there's a real sense that this is only relevant for erectile dysfunction. So next slide, please. It's mainly raising your awareness of the ability of our brains to put the brakes on. And actually, I often describe the brain as being like an amplifier, like a volume switch. So if we pay attention to what's happening in terms of sexual touch and our arousal, and really focus in and ground on that sensation, then our brains can act as a volume switch turned up and really draw our attention to what's happening and increase our turn on. But what's happening much more at menopause is it's doing the opposite. Our brains are busy with the worries from the day, anxieties around response and pain, distracted by what else we're carrying at that time, or even dissociated because trauma may be coming up for us. And there's a lot of overlap between trauma and menopause symptoms at this stage. 1 in 4 women will have experienced sexual trauma, and we know that PTSD symptoms can become more pronounced at menopause. So sometimes women are actually almost stepping out of their bodies during sex and dissociating, and again, that has a massive impact on arousal. Next slide, please. So it can become a vicious cycle. What's really important in terms of working with patients from this perspective is to go back to just working on your own, to encourage privacy, and to practice bringing your mind back onto sensory sensations. So I often do a body scan or get women to focus in on sensory input, what they can smell, what they can feel, what they can hear, the temperature of their skin, and so on. And it's a form of mindfulness. And we know from research that other forms of mindfulness also impact positively on sexuality, because it's all about being able to notice the noise and the traffic in your brain and bring your focus back where you want it to be. And starting this practice with patients can be incredibly useful and can help a lot with arousal and interest and picking up sensations from the body. Next slide, please. Almost finished. Last one really is that all I hear about sex when I look at some of the social media and some of the conversations around sex is that it's all going to get better with testosterone, a vibrator, and some lube. So I'd like to bust that myth if we can go to the next slide. There's truth in the fact that if we increase the intensity of sensation, that's really important. So vibration sensation, for example, gets reduced as we age. So sometimes we need to change the kind of stimulus that our body's receiving. But we also need to make sure that we've done all of the basics that we've talked about already to remove the barriers and then work with an individual or encourage them to go and see a psychosexual therapist so that they can be worked with around remapping their body at this stage and remapping their mind, encouraging them to consider sexuality from their own perspective, because most of the women I see in clinic think of themselves primarily as a partner and how a partner may experience their body and their interest in sex rather than having it centered on their own interest. So we do a lot of work around erotic palette, exploring things like fantasy and erotica, taking away goals from sex. So the idea that we have to orgasm or that we have to have penetration, moving away from that can be incredibly important too. And making foreplay the main event, taking away that idea that it's something that we do quickly to get to the main event, but encouraging women to consider that sex as a buffet more than a 3-course meal can sometimes give freedom in this aspect. Next slide, please. And fantasy has a really important role. There's a brilliant book by a guy called Justin Miller called Tell Me What You Want. And he's studied 4,000 individuals at different ages and stages with different gender identities in terms of their sexual fantasies. But what I thought was interesting is that middle-aged women have some of the most adventurous fantasies. There's more novelty, more multi-partner sex, more taboo activities, more non-monogamy. And the theory around this is the constraints of our lives at this stage, long-term relationships, lots of sort of social and cultural scripts about what we should be doing means that we search for more novelty and freedoms in our fantasy world. There's evidence that if we can share fantasy with a partner, this often correlates really well with relationship satisfaction and sexual satisfaction scores. And it allows you to bring novelty in, and novelty is really important for arousal and interest. We need our dopamine to be spiked by what we're doing to want to do more of it. I think we're on to the last slide, Fiona, if you go there. Yeah, it's just this message again, always around sex, that one size does not fit all. We cannot assume that giving one treatment, and namely that's testosterone most of the time, is going to solve a problem as complex as sexuality. We need to think more widely than that. If you skip through the next one, there's a slide that gives some useful books and resources, which are, given that we only have often 10 minutes with a patient, are quite useful to have in your list of things to try. Or you can refer a patient to a COSRAT or an IPM approved therapist. Thank you.